My introduction is about impact of nutrition of patients admitted to the ICU and throughout the patient's journey in the hospital. These are my conflict of interest, consultations or presentations, and the outline of my introduction is talking about nutritional care in the hospital. What are main problems there? What are the problems on ICU? The problems of catabolic status, risk of overfeeding and refeeding, and what are the needs of patient and what is the reality we are able to give to our patients. What about discharge from ICU? Is this problem or not? Is this problem with nutrition or not? I think that yeah, because of risk of underfeeding, with lack of nutrition monitoring and low physical activity. And what about after discharge from the hospital? Are we able to follow up our patients with the nutrition? And what is necessary? I think that we will talking about cumulative balance of energy and proteins because we have to know how much calories and proteins our patient lose. So, what are the main problems on ICU? How much energy, how much protein every patient need? How much energy, how much protein are we able to give to them? And what are the intolerance of enteral nutrition? And this was the topic Professor De Waele will talking about. I think that there are 5 key problems of nutrition for critically ill patients. The first one is catabolism in the critically ill, but this is not issue of nutrition because catabolic status, we must treat it itself, and we are not able to reach all energy needs and protein needs of our patients. The second one, during the acute phase, the measured energy expenditure should not be the nutritional goal because of insulin resistance, and we are able to measure it, but we are not able to solve this problem and take to our patient enough of energy and nutrition, but we have to know it and document it. Endogenous substrate production should be quantified, but this is very, very hard to quantify it. And any study design should consider biological and clinical data, and we have to be aware of rehabilitation phase about recovery of our patients. This slide is very known, so this is the phases of each patient's disease. In the first 1, 2, or 3 days is acute phase, early period with the catabolism, and then in the late period we treat our patients and their shift from catabolism to anabolism. It is our goal, but that could bring to us and to our patients some problems. In the late phase, we have to try to treat our patients, but nourish them, not only treat, but think about malnutrition that could origin during the ICU stay of these patients. And here you can see some guidelines for ICU admission for targets that are different in the acute phase, in post-acute phase, in post-ICU phase, and post-hospital discharge. And this is not my topic, this is a topic of each of our experts here. And we have to think about intolerance of enteral nutrition because we have some tools for it, and enteral nutrition is necessary, but some patients are not able to tolerate it, and this could bring for patients underfeeding during the hospital stay. So the second phase is anabolic shift and the risk of refeeding syndrome, and we have to know about it, and we have to know how to treat it, and we have to be aware of not only energy need, but phosphate, thiamine, potassium and magnesium needs, and monitor it and apply it to our patients. So what are the phases? The first phase is critically ill patients with catabolism. We must be aware about overfeeding. There are energy needs, and we have to wait, but we know it, and we have to document it with cumulative balance of energy and protein requirements. Second phase, we treat our patient, we are successful, and during anabolic shift, the patients could origin hypopotassemia, hypophosphatemia, and mobilization of fluids. And during the long stay on ICU, the patients can have a decrease of nutritional supports because of problems with enteral nutrition, and we have to be aware about underfeeding. So this is the second stage, optimizing post-ICU recovery. And what are risky? After improvement of patient status and starting of oral intake, the patients start to eat, and there's no need of artificial nutrition. It's some myth of some doctors, some physicians. I don't say surgeons, because Professor De Waele is surgeon, so I have fear about it, anything about it. But mostly it's the problem that when if the patient start to eat, that no artificial nutrition is applied to these patients, and it is decrease of intensity of patients' nutritional monitoring, and the finish of application of nutritional support. So, as you know, the patients can lose about 15,000 to 20,000 kilocalories of energy, and about 500 to 800 grams of proteins. It is about 4 kilograms of lean body mass after 1 week on ICU, and we have to give back to our patients in the recovery phase. You know, Minnesota semi-starvation study, and during recovery phases, the patients needed about 4,000 or 5,000 kilocalories of energy to weight gain, not 2050, but 5,000, and that were health persons before this starvation in this study. So, and the last presentation will be about the problems of nutrition after discharge from hospital. I think, and not only me, but I am sure that Professor Keller also, that is necessary to monitor nutritional intake of our patients after discharge from the hospital, and have post-ICU outpatient department and monitor these patients to improve their nutrition status. So, it's the finish of my topic, and I would like to ask Professor De Waele with her speech.
So thank you for the introduction, and indeed it was a nice introduction to what we will be talking about, and also the fact that we are united here, the dietitians, the medical doctors, internal medicine, and all the backgrounds, and also in the room, all the people that are fighting the same fight against malnutrition. So thank you to Nestlé to bring us here together. Now, it's also very reasonable that we should consider that we have different feeding strategies. And different feeding strategies are available because our patients are different and they will need different strategies at different time points. And to optimize that use, one of the things we should think about is what is the challenge and what is the gastrointestinal function and dysfunction. And a GI tract is quite, a black box. You have CT scans of your lungs, you have a lot of meanings, but really look inside a stomach or an intestine and know what's going on with your GI tract during critical care and afterwards. It's not so easy, and it's not easy for us as clinicians to be able to guide your therapy. So let's go into that topic, and those are my disclaimers. So some questions. Yes, are we doing a good job? I think we can still improve, and we are many here to learn, but we have many more colleagues that can improve knowledge, and we can certainly do better. What about this GI dysfunction? And of course, we won't leave you here unhappy. We will also see some solutions that we have figured out and that many of you have also implemented or could do. Now, we have seen an evolution over time, and many more experienced intensivists are in the room here who tell me that over decades, the profile of our patients has changed dramatically. Even in my limited experience of 15 years of ICU, you could see the trauma patients, the construction workers, the young people going down in their prevalence in ICU. And we see an evolution in European countries to more older people, polymorbid, who have a lot of different situations together, different challenges, who are going in and out of hospital and ICU. So the profile of the patient has changed, and this is also something that the healthcare community should follow and is following, and this is what we're doing. So we have more and more people who will survive, but we have to follow them and take care that all our efforts in intensive care are not, unused and are not going to fail afterwards, so that we have this whole trajectory, and this is why we have this nice combination of people here today. Now, in intensive care, there has been huge amounts of, people combining energy, clinical nutrition, clinical studies, basic studies, but also technology evolving. And we have now, as a nutritional therapy, we have made large impact, and we have more, tools and ways of fine-tuning our treatment and making it real individual. So we can measure body composition, metabolic rate, we can keep track of what the patients are having as energy and protein, and we know the things that are important. So we are a little bit, coming to the same level as you have other treatments in ICU. So there has been a good evolution over time to guide us in our clinical decision-making. But still there are many challenges. And some years ago, we wondered in our institution in Brussels, are we doing a good job? Because, show me the data. You have to know where you are. So we wanted to know the adequacy of feeding in ICU and the same patients after ICU. So patients who stayed for more than 7 days in ICU. Some of the patients were also COVID patients. So we could see that in ICU, both on an energy and protein, we had some challenges, especially in the protein side. So we were in energy, depending if you're aiming at 20 kcal or 25, the energy was quite okay. I repeat, normally we are above 80, 85, but during Corona we had a large influx of patients, so it went down a little bit. The protein was a challenge, but when you look at the pinkish colors, which is in the ward, the same patients transitioning from ICU to the ward, they were the biggest challenge. And these were the dark numbers as we published it. It's the dark trial. And this is something that we can improve. This is something where you can work on, that you can measure again after your implementation of improvement programs, and you can see if you're actually doing a good thing. So for yourself also, please know what you're doing, get the numbers, get the information, and work on that. Now, when we get the data from this observational trial, we were also doing some sub-investigations, because in the meantime, all this, more protein is better was being questioned. So we took the data and we went back and we saw what is going on. Well, in our limited one-center data, we could see that for energy, the U-shaped curve that was, historically and became very famous by the team of Pierre Singer, it's still valid. So the fact that underfeeding is not a good idea and the fact that overfeeding is not a good idea is still valid today. So this, the lower the better is not the signal that we get from our numbers. And also a very nice illustration by the team of Professor van Zanten, where you can see that when you compare European and American guidelines, apparently also for protein, there would be this kind of optimum that is somewhere in the middle. So we are learning from the data. And we can see that, yes, we have a safe zone. We have a safe zone of nutritional therapy where we can actually have a mortality decrease or a survival benefit. So the power of nutrition is proven over and over again. Now, I won't go into detail because, of course, you know better, but very interesting here was that indeed there is not only the dosing, there's also the timing, and we know that we've been talking about it. But I get scared when I see clinical practice being performed by MDs, by medical doctors, intensivists, who are big specialists in something else, but not in nutrition, and they hear this thing of, oh, protein's no good anymore. Let's go lower, let's go lower. And in the end, you're doing harm to your patient, because in your data you could see that when you are careful in those first days, but then you ramp up, and I think there's also some data from Professor Weiss here in the room, that when the acute phase is done, you really have to step in, because then you have better survival, you have better cumulative survival when you are doing what you're supposed to do. So there's the timing issue is very important, and you don't have to, stay on the same lane for weeks and weeks. So careful early and then do what you have to do. Now, we were at the honor to contribute to one of the trials investigating this, let's say, high versus low. So what we were actually doing with many centers in the PRECISE trial is that we compared in enteral only, let's say, the American guidelines, and we achieved 1.9, to the European guidelines, and we achieved 1.2 at the same energy level, which is important. This is a protein trial with the same energy, and some other trials are not doing that, and that's quite confusing. Now, after this big and well-designed trial that was published in The Lancet, we discovered that it didn't prove to be very good to go to these very high levels, but there was, first of all, no mortality difference. So our patients have the same survival chances in both groups, which is, in this case, good news for America, where, they are going higher than we are going in Europe. Because if this would be, not the case, huge changes should have happened to our protocols all over the world. But we were reassured that we could continue the way we're doing. So no mortality difference. What is important to say is that, for example, in the female patients, the signal was not so strong. So the protein was more of benefit to the men than to the women. So this thing of looking for a magic number of grams of protein per kg per day, I think we agree that this is really not the good way to go. We should get away of that question, because it's also based on the weakest parameter in intensive care. How much do your patients weigh? Our 74, because in most of the time we don't know, and the nurses will put 74. So this is the weakest way of working, and we spend millions of euros investigating a magic number, which is a bad idea. Now, we were indeed already talking about this, and it has been shown by the chairman, that the opportunities probably once the patient has stabilized, and this is where we want to be, and this is where the opportunity for you is. And it's not only this post-acute critical illness, but the whole trajectory of care that we are talking about. Now, if we know that we have an opportunity, that we have the duty to step in after a few days and do what is supposed to do, get our patients to energy and protein target, whatever it takes, then we have to think about what are we going to do? How are we going to provide the energy, the protein, the micronutrients to our patient? And what about the gut? What about the GI tract? Now, I've been reading this paper a lot because it shows protein metabolism, and you know that there's an intake. You know that there's a conversion of free amino acids, and it's happening all the time. It's happening all the time because this transition and this makeover of proteins goes very quickly. And we know on the blue part that patients have a lot of reasons to lose all that muscle. You know, we know about the anabolic resistance, we know about procatabolic hormones, the disuse is there. So the sarcopenia is rapid and very quick and very devastating. So we know what's going on. But on the other hand, when you look at the pink thing, I was like, right, where is all the protein going? Where is all the protein going? And well, it's a little bit, you know, misleading, because if you do it in the right dimensions, this is what you get. The protein is used for the gut. The muscles are not so rapidly renewing. Somebody told me it takes 6 weeks to renew the muscles of your arm. But what about the gut? A gut is a very rapidly changing cell line. Think about patients on chemotherapy. What is the first thing that's going to suffer is the GI tract. But in the other way around, this is a cell line that needs to be rebuilt all the time, constantly. And this is why it uses up to 40% of all the protein that we are providing. Who thought that a kidney and a liver would use so much of the protein? So what we're actually doing is also healing the skin. You know that when you don't provide nutrients, skins and wounds are not going to heal. So I think that we could shift away a little bit from this focus on muscle mass and muscle strength and think about restoring the gut by feeding a patient. So this is quite eye-opening to realize that this is something we should focus on. And Saturday on the LLL intensive care, I was much inspired by Professor Hiesmeyer's talk, which is fabulous. And he explained that the energy is not used for muscles. The energy is not used for what we think it's used. It is used for cellular activity, for metabolic processes, to keep you alive. You have 1.5 seconds of stores. That's not a lot. So you can see that mitochondrial functioning, that, you know, pump and active pumping of ATP and so on. This is where the energy goes. So by energy, we are keeping the patient alive, and with the protein and the enteral feeding, we are restoring the gut and feeding the gut. So those are two different things. You want to keep your patient alive. It needs to be all the time and very rapid. And on the other hand, we want the body to rebuild and to recover. So those are different targets, and this is why we need different nutrients at different time points. Now, if we are motivated and we think, okay, we want to restore the gut, we want to keep the patient alive, and we have the opportunities, how are we going to decide what to do? Now, first of all, we need to realize that when you use artificial nutrition, you're just replacing normal food, because we are talking so much, you know, like what are the components, what should there be in the enteral, what are the components of the parenteral. We are replacing normal food, and this is what we're intending to do on a first layer. Of course, you have, you know, the field of micronutrition and so on, but in the first place, we are just keeping the patient alive by providing an alternative to normal food. Now, we have different patient profiles, and you have them too, and this makes that the decision on enteral or parenteral or a combination of both is not made by us and certainly not by experts doing research. The patient will be your guide. The patient will tell you, this is tolerated, this is not tolerated, and all of you who do bedside work, they know this. Of course, you're going to let your patient eat if he or she can eat, but when you calculate it, you know that eating most of the time is insufficient in ICU and after ICU. We had a poster on this Congress that actually said eating doesn't work after ICU, and it's true, it's been observed. Then you have patients that will go for enteral, and you have patients where you have, of course, immediate indications for intravenous feeding. If you see a patient in the room in intensive care, can you tell if the gut is functioning, yes or no? No, because you cannot see it. You cannot, you don't have good tests to know. But there is a possibility that inside the gut is not in a very good shape. Because when you go back and you go and see some research that's being done, for example, in mice models, when you have a septic situation, so when you do, puncture the cecum, as a surgeon, I get a little bit, itchy, like, ooh, why do you do that? It's such a nice organ. But when you puncture the cecum and your mice go into sepsis, you can stain the ileum, for example, and you can see the effect of a huge cytokine storm and a huge inflammatory reaction on the integrity of the gut. So what is happening in a patient has an impact on the gut, and of course, this will not be as efficient. So what is the efficiency of a gut in a critically ill patient or in a patient after critical illness who had a lot of influences. And all the other scary things they do in the research, for example, gastric lavage with E. coli, it is proven that in the septic patients or in the septic mice, it will also extravasate. So it will really move around and go to other organs. So we need to treat the gut with care. So how to know that bedside? How to know how the villi look of your patient? Well, this is a nice overview by, of course, a queen of gastrofunctional dysfunction. She left to the airport. I'm happy because, you know, I said I get too nervous when you're in the room. She provided, together with some colleagues, the judgment that clinical assessment is still very, very important to assess the GI function in intensive care. We don't have a marker that will tell you if the gut is functioning, yes or no. We would really like to have a CRP for nutrition and GI and so on. So you have to put things together, information, have this cloud of information, and we need better tools and biomarkers. So what to do in the meantime? There's been a lot of work by a lot of people. And here, for example, the results of a Delphi process where I was also involved, those are the things that we would, you know, classically use in our clinical practice to try and understand if our patient has a functioning gut, yes or no. But some of them are very imprecise. How about abdominal distension? Intra-abdominal pressure, you can measure it. What about pain in a patient who's in coma? Very difficult to know. So you can see all those things that we as clinicians will put them together and then make decisions, but it's a little bit a shot in the dark. You know, you're not really sure what you're doing. And then we have other barriers of adequate feeding. You have somatic functional disorders, and this becomes more obvious in a later trajectory, also out of ICU. There's so many reasons why patients couldn't eat or tolerate their nutrition, and we need to be aware of them. And this is my colleague, Professor Aerts, publishing and also having a poster here on all the reasons, the barriers of adequate feeding. Now, what to do? This is a first practical tip for you. If you're standing next to a patient, you can actually do this. You can make a nice checkpoint. You can make a nice Excel files. I love Excel files, you know. You just do it, and then you see, okay, where are we? What is the risk? Will there be a gastrointestinal dysfunction, yes or no? And you can actually also take clinical decisions based on this. So this is helping us. This is helping us in daily life when we stand next to a patient and we want to know what to do in the field of nutrition. Now, how to overcome those barriers once we identified them in a single patient? Well, my colleagues with a lot of experience in burns, they always told me, you have to be early with your enteral, really within hours after the accident, because otherwise it won't work anymore. So if you can see, early enteral nutrition, for example, is apparently something that keeps the gut in a better place and makes it more positive to have a gastrointestinal function test. So if you can use it and keep it usable, you know. So there is this interaction between the enteral nutrition you're providing and the gut that is in a more homeostatic environment. But remember, you will probably maybe not always be able to totally fuel the patient, so a combination might be necessary. So exposure to enteral nutrition is very important, and this is why we always say that enteral nutrition will be the first choice. It has many advantages. It's like less technical than you know, the catheter care in ICU. It's still okay, but post-ICU, that's a risk. Many advantages, and also keeping the gut in a functional state. And then I really appreciate a paper that was written together with Paul Wischmeyer, because there are also a lot of myths, like you have said, that nurses believe, doctors believe, and they said when we had COVID, the patients came and then somebody said, oh, you cannot use enteral nutrition in prone position. We were, why not? It works. So we have to challenge that. Maybe it's true, maybe it's not, but we really have to see that we are acting on evidence and not a story that's been told in the corridor. So this is a nice paper to see that you really have, in a lot of challenging patients, also the opportunity to feed your patient. And this is why, when you look at big data, in critically ill patients, enteral nutrition is always and will probably be the first and the best choice. And with that, I thank you for your attention.
So thank you very much, Mr. Chairman, Elisabeth, for handing over. And I'm going to address the next topic about optimizing post-ICU recovery, targeting ICU-acquired weakness and nutrition therapy in the window of opportunity. Here you see my disclosures. Now, I'd like to address a few topics in this presentation of 20 minutes or so. Why does ICU-acquired weakness matter for the long-term recovery of our ICU patients? When is the right time to optimize protein and energy delivery? And I will show you that recovery truly begins after ICU discharge, although we worked so many years on so many studies to improve nutritional care in ICU. Post-ICU nutrition, I think, is a key opportunity to transform the outcomes of our patients, although the amount of evidence or studies is very limited. So for that reasons, we have to do more work in this field, and I come back to that later. Now, why does ICU-acquired weakness matter for our patients with respect to long-term recovery? Now, you've seen this slide, I think, 1 million times. It's work by Zanten from London, showing that ultrasound of the leg, the quadriceps muscles, shows a decline in muscle mass in the first 10 days of ICU stay. Especially those patients with multiple organ dysfunction show huge loss of muscle mass, and it can, well, go to up to 25% of the muscle mass of the quadriceps muscles. And that translates in a general patients to a muscle mass loss of 1 kilogram per day. So that's a lot. If you go to the gym and you want to have it back, it will take you a month or 6 weeks with a high protein diet and maybe 3 times per week to the gym. So that's a lot of work to get it back. So like Carla Prado is telling us, it's like a wildfire in a forest. You lose it immediately, and it takes a long time to regrow the forest. Now, how to diagnose ICU-acquired weakness? Well, the most simple way of doing is to do the so-called MRC sum score. That's a way of testing the strength in arms and legs, and it adds up to a total of 60 points. And when it's below 48, we consider that to be ICU-acquired weakness, and maybe below 32, it's severe ICU-acquired weakness. Now, is that important or relevant? Yes, because the group from Leuven showed that those patients with an MRC sum score that is lower, for instance, than 36 or below 36, they have like a worse trajectory with respect to mortality. So ICU-acquired weakness is directly related to the final outcome of our patients. So can we prevent it to happen, or can we fight it? That's the question. Now, why do we lose the muscles in ICU? There are at least 3 main reasons for that. The first one is enhanced protein breakdown because of immobilization, disuse of the muscles. If you don't use the muscles, you will lose the muscles. The second one, and that's more than immobilization alone, is there is an inflammatory response in the muscles. So when you take a muscle biopsy, you will see inflammatory cells. There's some kind of myositis, probably to enhance the production of amino acids, maybe for the acute phase proteins. But when this is continuing and prolonged, you lose a lot of muscle mass. Now, the third factor important is the protein synthesis. And this is blunted. The effect of providing amino acids to the patient is limited, and this is called anabolic resistance. So in the context of the same amount of amino acids, the production of muscle protein will be reduced in ICU patients. And then, of course, we have to consider, is muscle mass important or not? So we do a lot of BIA, and we see sometimes that we see an increase in muscle mass in the first few days. How can that happen? Well, that's fluid overloading. That's edema in the muscles. And when you do BIA or ultrasound or CT scan, you have to take care of that because the quality of the muscles can go down. And we also know that there can be myosteatosis. There can be also infiltration of fat in the muscle, and that's not a high quality muscle. Now, with respect to muscles, you must know this lady from the Netherlands, Femke Bol. She can take the hurdles and run very fast, gold medalist. And I looked at her at her data, her length is 184 meters, so it's a very tall Dutch lady. Her weight is 65 kilograms and the BMI is 19.2. So severely malnourished or not? So what about the muscle mass in this lady? Very limited muscle mass, but maybe the best muscles in the world because she always wins the gold medal. So it's not only mass, it's also function and the capacity of the muscles to produce ATP and to function. So we should not forget it's not only mass, and maybe you can focus on mass also in the recovery phase, but you could also produce muscles with a lot of fat infiltration, and that's not what you want. You want good quality. Now, we wrote several papers on physical recovery after critical illness, so the ICU acquired weakness reasons that you get it in ICU, but also after ICU. And we found several mechanisms involved. For instance, injured satellite cells. The stem cells in muscles are, well, damaged, and some of them never recover. So there's also epigenetic factors. It can be nutrition, it can be persistent mitochondrial dysfunction. There is a lot of factors why there's a difficulty in regaining your muscle function and even muscle mass, as you can see here. And of course, we hope that by giving optimal nutrition, that we can fight this problem and having a recovery in the patients. And there are some small mechanistic studies now also suggesting that after ICU, that exercise again can increase the muscle protein synthesis. So that's important to consider, something that is probably not present in ICU due to the anabolic resistance and low ATP content in the muscles. So we're talking about post-intensive care syndrome, and we do a lot of studies in this field, and not only focusing on the physical domain, but also the mental and cognitive domains. And you can imagine that a patient with post-traumatic stress or depression after ICU discharge is not very motivated to have an optimal feeding intake or to perform a lot of exercise to regain the muscle. So this is a multimodal problem. We have to do several interventions to improve those. We know by this work of Margaret Herridge, showing that in ventilated patients with ARDS, that 5 years after ARDS, still the walking distance performance is only 60% compared to age-matched control. So there's something wrong, and Elisabeth already alluded to it. There's a 1 to 2% breakdown and regeneration of muscles per day, so every 3 months or so you have new muscles, but it doesn't happen in patients who have been in the ICU. Now, it's too early to say we cannot fix this, because we have to focus on maybe the window of opportunity. And this is a paper we showed also for not only ICU patients with non-COVID-19, but also with COVID-19. And there is some indications that also in these patients we see these long-term consequences of weakness or the post-COVID syndrome, post-acute infectious disease problems. Now, why are proteins essential? Of course, the amino acids are the building blocks, and it can stimulate anabolic pathways. But, well, we've seen enhanced breakdown, reduced synthesis, so there is a problem in the ICU. And this is an elegant study by Leanne Chappell and Imre Kau from Australia, and they showed that in ICU patients on day 4, using labeled isotope of whole proteins, that the digestion and absorption of the amino acids is normal. It's maybe slightly delayed, but over a few hours the amount of proteins absorbed as amino acids is the same. However, if you look to the production or the synthesis of proteins in the muscles, this is, well, reduced. So although there is an abundance of amino acids, the effect of muscle protein synthesis is limited. So there is a problem here. So we have new insights that, also based on the studies that Elisabeth already showed, that going very high in ICU is not helpful. It can be even harmful for patients with high SOFA scores, with AKI, maybe in female patients and so on. So we have to focus on another time window. What is the right time then to induce this? Because feeding in ICU is during metabolic stress is challenging, is not very helpful, and we have this myriad of reasons why it doesn't work. We have insulin resistance, catabolism, mitochondrial dysfunction, autophagy suppression, thyroid hormone abnormalities, refeeding syndrome, anabolic resistance. So we cannot feed more in ICU. So we have to go to the second phase after ICU discharge. So feeding in the post-ICU phase is most important. Recovery truly begins after ICU discharge, but are we ready to support it? What's happened there? So I think there's the window of opportunity. Now, we don't have guidelines. And of course, when you look in other guidelines, like in cancer patients, surgical patients, geriatric patients, most of our patients are elderly, you see that the energy goes up to maybe 30 kcals, and also the proteins go up to 1.5 to 2.0. Grams per kilogram body weight per day. And that's more than we recommend in ICU. So after ICU, we have to go up. And already alluded to by the chairman, we have the Minnesota Starvation Project. These were healthy males that were starved to a BMI of 13, 14, and then were refed during 1 year with exercise. And the intake of those males was 2 to 2.5 grams per kilogram body weight per day and 4,000 to 4,500 kcals for a year. And if I ask my dietitians, they say this is impossible to achieve in normal eating elderly people. That will never be achieved. So we have to consider what to do. And there's so many reasons why feeding in the post-ICU phase doesn't work. Patient factors. Poor appetite, functional problems, dysphagia, depression, but also the hospital system is important. Now, what's happening in the general wards? This is work by Emma Ridley showing that in patients in general wards, if you only rely on oral nutritional intake, so normal hospital food, well, the energy intake is about 50%, but the protein intake is only 40% of the target, so a huge deficit. And when you combine with ONS or EN, the tube feeding, it's better. We also know from this study that the prescriptions in general wards are too low, around 70% of what it should be. And of course, a patient will never eat what you order or what you prescribe. It will always be slightly lower or markedly lower. So we performed this study, the Prospect 1 study, by one of my PhD candidates to look at the intake in post-ICU patients. And I'm very lucky. I work in some kind of hospital hotel service environment. We have a call center. You call to the call center and the food will be freshly prepared and sent to the room within 30 minutes. And you see on the menu list the green thumbs up. That are the high protein products. And then you go to the cashier of this call center and they calculate how many proteins and energy you have ordered. So we know exactly what has been ordered, but that's not the same as what has been eaten. And therefore we use digital food intake scoring lists, so you can estimate 25%, 50% of the intake. And then the computer will calculate exactly what is the intake of the patient with respect to energy and proteins. Now we tested whether the scoring of healthcare practitioners, dietitians, food assistants and nurses is okay. And we found the accuracy is very high. So it's less than 10% wrong, if you wish, compared with what we exactly measured in test meals. Here you see the test trays. We discarded parts of the food. We weighed all the food, so we knew exactly what was on the plate, and we tested it. But now the good news, we also tested patients and family. And we found they're as good as healthcare practitioners. So we can use co-creation with the families and the patients because they can help us to score their own intake, and maybe this also help them to consider that feeding is important, some kind of Hawthorne effect. Now, what were the results of the Prospect 1 study? Now, we made photographs, you see the cameras here, before and after the patient had eaten the meal, and we calculated exactly what was the intake per patient. And you see the cable and the lock, because after 1 week all the cameras were stolen. Yeah, so that was a problem. And sometimes you miss some elements of like this is some kind of apple compote or so. We found it back in the refrigerator of the family at home, so it's not always eaten by the patient. Now, we found on average maybe an intake of 70%. So our hospital is maybe slightly better than other observational studies. However, we showed that the moment you take out the nasogastric feeding tube in the general ward, the intake of energy and proteins is catastrophic. It drops the next day by 50% for proteins and 45% for energy. So the nasogastric feeding tubes are removed too early. So we thought about it, can we transform this performance? What can we do? So we designed a new protocol, and we tested this protocol in the Prospect 2 study. We had a poster on that, and it will be published very soon. It's now under review. And we wanted to measure the primary outcome, the daily energy and protein adequacy of this new protocol in the first 14 days after ICU discharge. And we measured also physical function, length of stay, and other clinical endpoints. Now, the idea of the protocol is not removing the tube, not lowering the intake of enteral nutrition. No, you can say to the patient, you can eat, and if you are able to go over 100% of the target of the cumulative energy and proteins from EN, ONS, and oral feeding, then we will lower the EN the next day. So it's another way of thinking. Only go down when there is proven intake and not wishful intake. That's what we do mainly. Now we tested it and we included patients on enteral nutrition in the ICU for at least 72 hours, and then we measured this protocol. So you see it's a step-down protocol. In the middle we introduce ONS, and at the end we wait at least 24 hours to be very sure that we can remove the feeding tube. Okay, now the results. We showed in the population of these patients that the energy intake was 100% and the protein intake was 97%. So it is possible to have an optimal intake after ICU discharge, but you have to change your way, your strategy of doing it. And those patients who did not follow the complete protocol, because sometimes the patient takes out the feeding tube, or a doctor or somebody else takes it out, and every day you don't follow the protocol, you see that the intake of the patients is lower. So it's important to follow this, and on average the intake of tube feeding was about 5 to 6 days longer than in the Prospect 1. So patients need time. In the Prospect 1, we saw that when you take out the nasogastric feeding tube, it takes a week before the patients go back to the optimum. So that's important. Now, for this reason that we think that post-ICU nutrition is very important, Professor De Waele, she is the chair of this group, and I have the honor to be the vice chair. We started a new initiative. It's called the Global Research Initiative on Post-ICU Nutrition. So we have convened like a group of international experts with expertise and publications in this field. We had the first meeting this year. We have a meeting in a few hours with this group, and we focus on improving research in 10 domains in post-ICU patients. So if you want to join us in the future, you're happy to join this initiative. I've showed you that persistent catabolic response in ICU patients is likely not very helpful to increase the feeding. It can be riskful, it can be harmful. So the window of opportunity to increase your feeding intake, both for energy and proteins, is after ICU discharge. However, the performance there is very poor. So we have to learn how to do it. In ICU, you have anabolic resistance, all kind of problems, immobilization. After ICU, you can start exercising and combining with nutritional intervention. And we have shown you that an individually tailored stepwise nutrition protocol implemented after ICU discharge is able to achieve a very high adequacy of energy and protein intake in the first 14 days after ICU discharge. It comes with the price, more EN, more ONS, but maybe that's good for the patient for their final recovery. So I think post-ICU nutrition therapy is most likely the window of opportunity, and we have to do more work in this field. With that, I'd like to conclude, and thank you for your attention.
Well, thank you very much first off to Nestle for having this amazing symposium and great speakers to hear about ICU and post-ICU nutrition care. And also thank you to you folks. The last day, full day of ESPEN in a hot room last symposia, last presentation, and you're still here. So really appreciate that. We're going to be switching gears and talking about discharge. And so this is obviously quite different than the ICU, and in the general ward we may have more data and more control over what happens to patients. You'll see that the change means not so good things for our patients, unfortunately. These are my disclaimers and conflicts of interest. So the outline, I'd like to cover why is post-discharge nutrition care so important. I think we've already heard a little bit about that, but what do we know about the typical discharge process in nutrition care? And there's actually not a lot of research in that area. What are the best nutrition care practices for these transitions? And there is quite a bit of evidence, and so I'll be showing you some systematic reviews around that evidence. And then how do we support effective patient care during transition? This gets into my area of expertise, which is implementation. How do we actually change practice and change protocols? So why post-discharge nutrition care is important? Well, just to show you, in Canada, Czechia, and Germany, the proportion of people that are coming into hospital based on the population size, you can see it's huge, right? And so it's about anywhere between 1 in 5 to 1 in 10 of the population will end up in hospital in a year in our countries. So it's a large number of people. Then we look at just the public sector hospitals only. About 64 million people in the EU are admitted to hospitals every year. So again, a huge number of people. And when you think about they're coming in, and often a third to a half are malnourished coming in the doors, and if they're leaving that way, we've got a huge issue with discharge, malnutrition, and nutrition care. If we look at the length of stay, now this is not including the ICU, obviously, but it's the OECD data that we have for 2021, we can see in general, outside of Japan, which is a bit of an outlier, about 1 week is what people spend in hospital. So we're not solving malnutrition in the hospital. We are perhaps detecting it at best and starting them on the road to recovery. We also know from some of the work that has already been presented today, and perhaps other things you've seen at this conference and before, that we are not always being able to address fully the malnutrition. We may be even causing some of the problem, right? So hospital-acquired malnutrition occurs in about a third of adult patients in general and surgical wards in the world. Suboptimal care and intake on wards post-ICU stay is due to food access barriers, including some of the work that was just presented. Spontaneous oral intake post-ICU is as little as 700 calories a day. So it's nowhere near what it needs to be. We know this is from my own work in Canada. Food access barriers are significant. About half of your patients will experience at least one barrier, whether it be being able to reach their tray, even getting food, or missing their food because they were sleeping or at physio or something like that. Longer stay means more malnutrition at discharge. So 36% of people are malnourished at discharge, and if they stay 15 days, they're very likely to be malnourished, 80%. And a quarter of patients, again, this is data from Canada and BC specifically, a colleague of mine, a quarter of patients discharged from hospital to home care in Canada are malnourished, and a half of them are at risk of malnutrition. So 75%, all right, are very high risk and ending up in home care. So we need post-discharge care for sure. The challenge is discharge planning is inconsistent. I'm sure it's in Canada it's the way, and I'm sure it's this way elsewhere as well. About 1 in 10 patients will see a dietitian in a hospital. And about 4 of those people, or 5, will see a dietitian at a follow-up appointment. That's a huge number of people who've not seen a dietitian in a hospital and perhaps not received treatment. Patients do not meet the nutritional requirements or recommendations from the hospital as well. So we might say, take 2 ONS a day, and that doesn't happen for a variety of reasons. There might be some of the psychological challenges we've spoken about, or perhaps there's financial challenges or other systematic challenges for these people. But we see that only about 18% will meet a goal of 1.2 grams per kilogram per day for protein. Less than a third are going to meet their sex-specific energy requirements, and less than 15% are going to meet their fluid requirements. So it's not just malnutrition, but also dehydration that we have to worry about. And we know that ICU patients specifically do not recover their body weight post-discharge, and lots of great data was already presented about those issues for you today. So what are some of the consequences of this malnutrition post-discharge? And this is a systematic review based on 26 studies and over 9,000 patients. People that had been admitted to inpatient or subacute care, so not ICU, unfortunately, we don't have that data. But they looked at, were these people identified to be malnourished, have sarcopenia or frailty, and looked at outcomes of these individuals based on that diagnosis. And you can see that for malnutrition specifically, we have 9 studies, and it was typically diagnosed within 4 days of admission. And they found that malnutrition specifically was associated with discharge to a higher level of care, poor quality of life, lower physical function, and 3 of the 5 studies also reported increased mortality. That reported mortality showed an increased mortality when there was malnutrition there. So definitely there's consequences, as you well know, of this malnutrition post-discharge. So what are some of the needs and gaps around this nutrition care? Well, this is actually voices of patients who leave the hospital. So we have from the UK this qualitative study. You can see that patients feel like they're being pushed out the door often to meet a weekend agenda and don't get to stay in as long as they need to. They might not have heard about what to expect when they get home or how to continue the nutrition care post-discharge. Nobody came to discuss what you were thinking about nutrition-wise. And when you get home, what you get in services may be totally insufficient. You can't function at home. You don't necessarily have the home care support or family support to support you successfully at home. No wonder we see huge readmissions into hospital from people leaving hospital. So this poor transition experience results obviously in readmission. And when a study was done actually looking at sort of a review of patients, so geriatric patients, due to coming back into hospital, what were the reasons why? It was malnutrition was one of the big reasons, reduced mobility, risk of falls, et cetera. But malnutrition was a key reason why your geriatric patients come back into hospital. About 1 in 5 patients who stay more than 5 days are going to be readmitted within 30 days. This is actually data from our Canadian study, the prevalent study that we did in 18 hospitals across the country. Oops, sorry. Enteral nutrition is going to be associated with more rehospitalizations, with 23% being readmitted in 30 days. And those requiring home nutrition support are more moderately or only moderately ready to manage that care. So again, they're not feeling ready. They may not have received the education or the support that they need to have that home nutrition support. So it's really important that we have home nutrition teams that support these individuals. And finally, the older patients report poor transition experience. Again, probably half or more than half of your patients are older adults, and there is this lack of care that happens, unfortunately, for them. This is the group we need to target for changing practice in our care. So when I looked at the literature, outside of the work that my group has done in Canada, there really isn't anything describing the nutrition experience in general for people leaving hospital. So the first on the left-hand side from 2017 was based on a study we did 2010 to 2013 in Canada in 18 hospitals. We followed patients and we didn't change anything about them. It was an observational study. We wanted to see the prevalence of malnutrition and what happened to these patients. What's a typical scenario in a Canadian hospital? It was not nice. It was not pretty, what we saw, unfortunately. This study was published a little bit later, but we had data from post 30 days of admission. We called all these patients. We had 747 out of 1,000 patients that we were able to call. 11% reported dietetic care post-discharge, either going to see a dietitian in a home care scenario or primary care or an outpatient clinic. And those who did see a dietitian were more likely to be severely malnourished at admission when we had that data collected. They also experienced or reported more weight loss post-discharge. They had more comorbidities as identified again during their admission. And they had a dietitian consult during hospitalization, which means we as dietitians were not necessarily doing the discharge piece as well as we should have, unfortunately. Skip ahead 5 years, and though it's only 2018 in terms of publication, this was actually conducted a study 2017 to 2018 where we actually changed practice in the hospital to show you that when you do change practice, you have better things going on for your patients. This was 5 hospitals, part of an implementation study where we implemented best practice with respect to screening on admission within 1 day of admission, SGA to assess the person in terms of malnutrition if they were at risk. And the SGA was used to triage people into advanced nutrition care or even higher care than that, specialized nutrition care with a dietitian. Advanced care was MedPass and more nutrient-dense diet, or regular care and discharge planning. And so these 5 sites worked on all those aspects of care, including discharge planning, and we can see an improvement as a result of this. So 42%, the proportion seeing a dietitian was the same, but in terms of the other activities, they were very similar, so, or higher, I should say. 42% were getting nutrition recommendations prior to discharge, so someone was doing something for them, and they were not feeling so in the dark when they left the hospital. 65% were reporting compliance. You might think that's low, but when you think about it, that's actually not bad. 27% report taking ONS post-hospitalization. What predicted that was being malnourished in hospital, taking ONS in hospital, and belief that they were not doing well with their nutrition. So they'd gotten the point that their nutrition was important and they needed to support in some shape or form. So let's talk now about some of the best practices in transition care. Well, first off, we are highlighting, as you know, in this symposia, high protein and high calorie nutrition in the form of ONS. And the reason why these are so effective are numerous. Patients often feel overwhelmed at discharge, and so one single thing can, if it can be put into place, might be more effective than many things. They're often still feeling unwell when they're discharged, and so they have poor appetite, they might have challenges making food, organizing food into the home, that sort of thing. All those challenges that impact their food access are going to be present post-hospital discharge. And we know that ONS are going to be concentrated, they're going to get a small amount and lots of nutrition, they're going to be efficient to support their nutrition requirements, easy to consume, they're treated like medicine by patients and the prescribers, and they can be used obviously in combination with other approaches, which we'll talk about with some of the systematic reviews now. So here we have a systematic review post-discharge patients, 14 randomized controlled trials, medical patients only, over 2,000 of them, moderate trial quality. But you can see the interventions were typically multi-component, but some were also just individual component. Excuse me. So dietary advice and counseling was 6 of the papers, food fortification and additional food was in 2 papers, ONS was being provided was 5 and prescribed was in 2. So getting the amount right is kind of important as well, right? The key findings that in all of these studies, when we put that data together, any kind of nutrition support to these people leaving hospital decreased mortality, increased their food intake, protein, increased their body weight. There wasn't a difference, though, in this analysis with hospital readmission or hand grip strength. I wanted to pull out one specific study just to show you the difference in body weight when you look at a multi-component intervention, which is on the right-hand side of the slide, and the control group. You can see over a 6-month period, the proportion of people that are changing their body weight, very different, right? When one is getting some kind of treatment versus the group that's not getting any treatment. It's dramatically different. So we need to be treating these patients, obviously. So in this study, it was specifically about ONS, and it showed that we can decrease complications of these patients when we provide them with ONS in and post-hospitalization. So this is all types of ONS in community settings specifically was the focus. There are 44 RCTs, and a meta-analysis including 39 of those studies. And the mean prescription of ONS was over 500 calories and over 20 grams per day. The compliance was about 77%, so not, perfect. And the intervention was on average 74 days, so more than 3 months, right? Okay, so, or just close to 3 months, I should say. 16 stays have a low risk of bias. What's important to note is those who got any type of ONS at about 500 calories, they have fewer complications. 20% had complications versus those who did not get the ONS, 40% had complications. And those are things like infections, falls, and post-op complications that might lead them back to the hospital. ONS significantly reduced the complications in the meta-analysis, and there was a slightly better effect seen when the ONS was started in hospital. So again, this process has to start in hospital and continue into the community. And so we need pathways of care and systems of care that do that process all the way through. Malnourished patients with ONS had lower incidence of complications, as noted already, and 80% of compliance seemed to be the sweet point with respect to finding significance in terms of these complications. Now let's look specifically at high protein and high energy ONS. And this was a small real-world one-arm study that looked at changes with these individuals. And these were 65 patients who are at risk of disease-related malnutrition. Mean age is almost 60. At baseline, almost all were malnourished, and 19% sarcopenia. When they received personalized nutrition intervention, which was a dietary consult with a dietitian as well as a high-energy, high-protein or calorie product, you can see the improvements in weight loss, malnutrition, severe malnutrition, and sarcopenia. If you look again at some multi-component interventions, we can see here, these are a little bit more recent than systematic review, so I wanted to include them as well. So in the first multi-component intervention, we had 6 months of counseling, so 8 sessions over a 6-month period, home visits, 5 of them, and as well energy and protein-rich foods, as well as ONS. Improved cognition, improved self-rated health, improved quality of life, decreased depression, and increased performance. That was the study by Blondel. The second multi-component study that was more recent, 16 weeks, it was a little bit shorter than the prior one. Individualized nutrition plan, counseling was given twice, daily exercise recommendation, and a food package for 24 hours when they came right out of the hospital, so they didn't have to worry about food access issues, and having samples of ONS. Here, the readmission rates were not different, but we do see an improvement in energy and protein intake, decreased weight loss, and improved quality of life. So this is one study that was specifically highlighted at this Congress, and it was an abstract, LB016, I think that was presented on Saturday. And we can see as well the benefit of a multi-component intervention with dietary counseling, high protein, high calorie, ONS, and physical exercise, a 3-month intervention. Not only reduced malnutrition, but also reduced inflammation in these patients when considering it by the GLIM criteria. So the challenge is, though, we know we can do things. Things work, right? The challenge is getting them into place, right? And that's, again, the work of what I do as an implementation specialist. So those who are most in need are the ones we have the challenge getting compliance from, right? And we know as well, the more interventions you put into place, this is a sort of against the multi-component method. I believe in the multi-component method, but too many things going into someone's home can be a challenge. If anybody works in home care, you know this sort of happens, that people get overwhelmed with the number of people coming into your home and talking to you about things, right? And so if you can streamline the intervention, at least in the first month to month and a half, especially around nutrition, you're going to actually really support that person much better. And again, we know from work that if we can meet those energy and protein needs in the first few weeks, we're more likely to have some success with that transition overall. So how do we do that? What are the best practices? You've seen this slide now 4 times today. We really like it. It's a very good slide. And I'm going to talk about the last little bit. But this is really good advice for a post-ICU patient, right? The idea that we have to get 150% of predictive equations for their energy, or about 35 calories per day, and 2 to 2.5 grams of protein. As already spoken about in the post-ICU ward, it's impossible to do that in a ward setting. So imagine once you leave the hospital, also extremely challenging to do. So back to the issue, what are the simple things that are going to work efficiently for you? Here's another very nice pathway of care, if you will, came out of Asia, and talks about the different roles that our multidisciplinary team needs to have. So physicians, nurses, dietitians, and physiotherapists. So there's a role for everyone. I'm not going to go through this in detail, and certainly the QR codes here will help you go right to the paper, which would be lovely. And I'm going to highlight this one. This one came out of Canada and under my work as well as part of the Canadian Malnutrition Task Force. And so we had done this original prevalence study, 2010 to 2013. We developed the best practice called the Integrated Nutrition Pathway for Care. We put it into 5 hospitals. Then we put it into 10 hospitals so we could do it again with no money to the hospitals to do it. And then we said, this is basically the pathway of care that we need to be following in this post-hospital discharge period. So the idea that whatever happens to people in hospital, you need to think about the hospital team doing that documentation of risk and malnutrition, doing that discharge nutrition care planning, educating the patient and family, and providing them with resources to get hooked up to things in their own community, such as Meals on Wheels programs, congregate dining, food access programs like grocery shopping, other things like that. Once they get to the medical home, hopefully there is now communication between that hospital team and their medical home. And we call it medical home because it could be a variety of things in Canada. It could be a community health center, it could be a primary care center, a variety of things. But in the medical home, that might be a week or 2. So you're going to want to reassess the patient and make sure that where they're not going further downhill than you had hoped post-discharge. Initiate post-discharge nutrition plans that they haven't gotten into place. Investigate etiology of various things that might be going on for the patient, especially post-discharge. Provide resources, monitor weight and appetite, etc. But key is if you have a dietitian, to link that person to the dietitian. Unfortunately, in Canada, Ontario and Alberta, which are two of our provinces, do have dietetic care in the community, but not everybody gets it, unfortunately. And often it's not the post-hospital patient that gets it. It is the chronic disease population that gets to see a dietitian, diabetes, that sort of thing. And so we need to be utilizing these dietitians for those high-risk individuals as well. In addition, of course, community-based services. So the prior one talked about what you should do. This one talked about what are the things that are the opportunities you should be putting into place specifically. So just to put that a little bit further for you, the Canadian Malnutrition Task Force, which I'm a part of, we've been in place now since 2010, 15 years of work showing that the improved practices can happen, but we need to do a real good job with respect to getting the grassroots to change practice, and also CEOs and others in hospitals to decide that this is an important practice. We've done a variety of things, and there's a variety of tools that are available for you. Again, at the QR code, you'll see a link to our site. But we have care pathways in hospital and out of hospital, as well as for older adults in the community in general. We've got screening tools for in-hospital. We use a 2-question tool. It doesn't require body weight measurement, so it's a little bit better than some other tools might have to require body weight measurement. We also provide a basic nutrition care plan. I think this is really an important piece. It allows a physician or nurse practitioner to start thinking about nutrition when there isn't a dietitian available, which is the reality, unfortunately, in community care. And so what can they do in terms of promoting care for that patient? Educating and documenting, investigating, promoting, referring and recommending, and following up. And this is just one thing you can see that's part of the promote component of the getting basic nutrition care plan. So I'm on time, I think. Good. All right, so takeaways. I think I've told you there are many hospital transitions per year. The length of stay is generally short, and malnutrition at discharge is very common. Nutrition care during transition is generally poor and affects outcomes of our patients. Treatment started in hospital and continued at home is best practice, and that's the pathway you have to put into place. Individualized care plans and counseling are essential. Multi-component interventions work. ONS certainly works, and now we're seeing evidence for the high protein, high calorie. Again, thinking about the small amount into those patients who have poor appetite and poor tolerance helps recovery as well. And finally, transition pathways have been created to support you with this better practice. So with that, I thank you, and we'll pass it on for our questions at the end.
So, thank you very much. I enjoyed all these lectures very much, and that was voice of my nutritionist's heart. So please, it is time to your questions. Yeah, please.
Hi. Hello. Thank you very much for your amazing presentation. I think it's such a needed work. My name is Maria, and I'm working as a critical care step-down dietitian in the UK. And I work with inpatients, outpatients after they are discharged from intensive care. And my first question is
please stay calm, yeah, stay calm and quiet, yeah, please.
I'm aware that you mentioned about the 4,500 calories that some patients get, but sometimes when I have like very little patients and they are receiving around 40 kilocalories per kilogram, I question myself, like, is there like any harmful like amount or like from your, so my question is, from your experience, would you continue like providing and increasing energy up to the moment that the patient is gaining weight?
We know thank you for that question, and thank you for your patience. So first of all, we know that in intensive care, there's this cutoff, like 4,000 to 10,000 kcal. This is when the complications come. Over the entire hospital stay, we don't really know where this number is, where the complications will come. But we have many data to show that when you have an adequacy which is lower than, let's say, 70–80%, your patient is going to be in trouble. So we really think that you should continue over the whole trajectory of care to be in a safe zone, and that will probably be, but we have to discover what that is, but at least it needs to be, 85%, this is what the protocols tell, 85% of the needs, and you use whatever is needed. It's a therapy.
Yeah, and maybe to add to that for the post-ICU phase, I think maybe we have to separate calories and proteins. So what for me was striking to see, if you look at protein metabolism in ICU and you see the production of urea as maybe a marker of not being able to handle the proteins, the urea genesis. Well, the association with the high UCR, urea creatinine ratio and hazard, is probably only found in the first 10 to 14 days of ICU stay, suggesting that when you overload yourself or your patient with proteins in a phase that is not, well, let's say severely anabolic resistance any longer, that maybe you don't use all the proteins, but you don't have the risk of increased mortality. So it's very phase specific. And also the overfeeding in the early phase is due to the fact that when you normally start eating, you will stop breaking down your tissues because, well, insulin will stop the production or the breakdown of glycogen, for instance. But in ICU, due to this catabolic response, you see non-inhibitable endogenous energy production, so not stopped by feeding or insulin. So I think the risk of overfeeding both energy and proteins after ICU discharge when the patient is recovering, and moreover when you can start to do exercise, because exercise will also reduce insulin resistance and will promote the anabolic signals for muscle protein synthesis. So there is a lack of data there. So I agree that maybe you are concerned, because also in the Minnesota Starvation Project, there are some indications that some of those healthy males develop myosteatosis during the recovery phase. So, and how to prevent this, we don't know. There are new medications coming up, also in the context of GLP-1 medication to lose body weight, and we want to prevent the muscle mass loss there. So I think in a few years, maybe we'll also have like medication that will help us to lose only fat mass and not muscle mass. But it's true, but I think personally slightly overfeeding the patient and giving more energy and protein to the patient because they have to build up new muscles and tissues, of course then you have to go over your resting energy expenditure, otherwise you will never build new tissue. So I'm personally not very afraid of overfeeding after ICU discharge.
And if I can give an example, so we have a study also to tackle malnutrition. One of our first patients in the study, the dietitians came back and they said, the study patient is drinking 8 oral supplements a day. Should we stop him? Because it is above the protocol. We didn't think about that when we designed the protocol, you know, because the big challenge is underfeeding. But what do you think? Would you say, no, you can't, you have to stop eating? I don't think so. So I align with you that both from a physiological and a practical standpoint, if the body is ready and the people and the patient can tolerate it, please let them have it. And if they're not able to do it by themselves, we will help them.
And we had the answer in the Minnesota semi-starvation study in the recovery phase, yeah, that Professor Zanten talking about. It is about 4,050 kilocalories per day to gain their weight. Yeah, so we have answer. So take these patients, eat and take ONS as much as they are able.
Thank you.
Because 35 kcal per kg per day, if you do that math for your own body weight, 35, that's not so much, you know, that's not 4,000. But maybe for you, but not for me. That's the surgeon getting the internal medicine.
The surgeon also.
I have another question, if that's okay. It's regarding the muscle quality that Dr. Van Zanten was mentioned. Is there like any way that us as a clinician we can assess and monitor like the quality of the muscle that our patients are gaining? And are you aware of any nutritional strategies that we can use to promote that high quality?
Yes, you can use very simple clinical tests like hand grip strength, sit and go, 6-minute walking test. So what is feasible and possible to do in your context. And maybe that kind of it's also in the discussion of frailty and sarcopenia, of course, should we only focus on muscle mass or should we also go for muscle function? And I think if you look like in ICU-acquired weakness, the weakness in the legs is more severe than in the arms. But for patients to be independent and be able to have a normal daily living, well, the performance of the legs is very important. So it's not only mass, it's especially also function. And we don't have so many studies focusing on function, and I think we have to do more work there. So we have to learn what are the interventions that not only lead to preservation or regaining muscle mass, but also especially regaining muscle function. So that's an excellent question.
Okay. Thank you very much.
So we have some questions from online. So what is the best nutrition intervention to prevent muscle weakness, especially respiratory muscles, and help warning of ventilator? Is this anything specific about type of protein intake in the ICU?
Quite interesting, that very good remark, because when we talk muscle, we think about limbs and hand strength, but your diaphragm, your heart, is also a muscle. So to answer the question, maybe you have a better response, but I think there is no, straightforward, this protein is for the diagram, this protein is for the heart. I think we should really stick to our ESPEN guidelines that tell you between day 4 and day 7, you should be at 1.3 gram per kg per day. I think this, just deliver it, the patient will use it, and this is, until now, still the best proven strategy.
Yeah, maybe one addition, I think the diaphragm is a muscle that's active in ICU patients in the bed when they're on supportive ventilation or breathing normally. So there is no immobilization in the diaphragm unless you sedate the patient or paralyze the patient for a prolonged time. And then you will see atrophia in the diaphragm. Moreover, mitochondrial dysfunction in diaphragm muscle has not been proven. So it seems to be that the diaphragm is a different muscle and also probably the myocardium. So we have to separate peripheral muscle, skeletal muscle from other organ systems. So that's something to consider. And then with respect to the magic bullet, what should be the optimal composition? Personally, I don't think we have to go very high in specific amino acids. So we did studies with arginine, we did studies with glutamine. We're not very successful. More and more, I believe that we need some kind of balanced amino acid spectrum. There's this idea that you can have maybe rate-limited amino acids. So when one is specifically very low, you miss some building blocks to make the proteins. So maybe we have to provide a more mixed, balanced amino acid composition. That's also very relevant if you consider like the plant-based proteins, because not all the products with plant-based have the same quality of especially essential amino acids, so that's something we have to study in the future. But, well, during recovery, we don't know. In other patient group, we know the effect of leucine or maybe downstream factors like HMB or other specific amino acids. But I think the proof in ICU to use specific amino acids or compositions that lead to a better outcome, well, this is very limited information. So we have to do more work there also.
So the second question is, I think, regarding to our microbiota. What is the role of fiber in post-ICU recovery?
Well, I think the real answer is we don't know. If you look at the microbiome, it's severely disrupted, but there is very limited information. Actually, one of my PhD candidates is doing a study now. We follow up patients for 1 year because we don't know exactly when this disruption, this dysbacteriosis in the microbiome is resolving or going back to normal, or does it persist for a year, and is there a difference in patients with ICU-acquired weakness versus those with a normal performance? We don't know, we don't have this information, so we have to study this. It is very likely that, well, at ICU discharge, patients have severe dysbacteriosis, and I personally believe the only way to help your gut microbiota is by feeding enterally. And they can use fibers we cannot absorb or metabolize as humans, but the bacteria can do this. So prebiotics and probiotics. There is a little bit of fear for probiotics in ICU because we had the Propatria study, the pancreatitis study showing like increased mortality. But if you look at all the data of probiotics, even in ICU, it seems to be rather safe. So maybe not in pancreatitis patient, this was also delivered in a post-pyloric fashion in a new product, never been tested before that study. So I think during the recovery, and I like this idea of Paul Wishmer, he's stating, well, we have to reseed or resod the lawn, yeah? You know, it's a catastrophe in the gut, and maybe we have to provide new bacteria, probiotica to have a new lawn in the gut, you know? That's a very challenging concept, but we have to do more work to do studies and to see whether this is helpful also to recover from PICS, from the post-intensive care syndrome.
So I think that we can see it on GI dysfunction after discharge. Yes? It's this point of view. So, ladies and gentlemen, thank you very much for your attention. And I'd like to thank you for all our experts and for Nestle Health Science for organization of this symposium. Thank you very much.
Thank you, Mr. Chairman.